Okay. Good afternoon, everyone. We are at the top of the hour at 2 p.m. I want to welcome everyone to this technical assistance webinar for RFA-MD-23-004. That's the community level interventions to improve minority health and reduce health disparities. And that's R01 clinical trial optional. My name is Crystal Barksdale, and I am a program director in the National Institute on Minority Health and Health Disparities in the Division of Community Health and Population Science, and I will be talking through this webinar with you today. I would like to introduce my colleagues who will be presenting and attending this TA webinar with me and who are going to be available to answer questions. Dr. Deborah Ismond from NIMHD and Dr. Jennifer Alvidrez from the Office of Disease Prevention are here with us this afternoon. So before we begin, I just want to go over and offer a few technical webinar tips and reminders that are listed on this slide. Participants will be in listen-only mode and are muted, so will not be able to ask questions verbally, but you are able and may enter your questions in the chat feature at any time during the presentation, but we will be taking questions and answering questions during the Q&A session at the end of the webinar as time permits. These slides and a recording of today's webinar will be available on the NIMHD website for future reference. So the following is an agenda for today's webinar. Briefly, we will first provide some background information about the RFA and then describe the research objectives and expectations. Then Dr. Ismond will discuss the peer review process and provide a general overview of review of applications. Then I will discuss the timeline for submission, review, and selection of applications, and then we will proceed to answer some participant questions. So before we begin, I just wanted to start with providing a little bit of grounding and discuss some key definitions, which are also included in the RFA. So when we talk about and refer to the term community, we're referring to a social group of any size whose members reside in a specific locality, share government, and often have a common cultural and historical heritage. Communities may be defined, such as the LGBTQ community in a city or county, or defined by the catchment area of local government or service providers. For example, residents served by a county school district or a community clinic. Examples of communities include, but are not limited to, neighborhoods, towns, cities, counties, school districts, reservations or tribal communities, military bases, or college campuses. Virtual or other communities that do not reside in the same geographic location are not a priority for this particular initiative. When we are talking about community level intervention, which we will discuss in much more detail in a moment, this refers to an intervention that modifies community characteristics, including the physical or social environment, laws, policies, or practices of organizations or governmental agencies within the community, and/or norms or collective behaviors of community residents. When we refer to community-engaged research, we are referring to a research process of working collaboratively with groups of people affiliated by geographic proximity, special interests, or similar situations with respect to issues affecting their well-being. Community-engaged research approaches emphasize collaborative partnerships with key partners, such as community leaders and knowledge holders, and leverage community resources to achieve community benefit via the research process. Examples of these approaches include participatory action research, community-based participatory research, team science, empowerment evaluation approaches, community asset mapping, and citizen science. NIH designated populations that experience health disparities are based on current designation that includes individuals who are Black or African American, Hispanic and Latino, American Indian and Alaska Natives, Asian American, Native Hawaiian, and other Pacific Islanders, socioeconomically disadvantaged populations, underserved rural populations, and sexual and gender minorities. So with that grounding in that bit of those definitions, I now wanted to provide a bit of background about this RFA. This community level interventions RFA is actually a reissue of RFA-MD-23-004. And this work was brought forth by previous work done by the NIMHD Community-Based Participatory Research Program. The NIMHD CBPR program was established in 2005 to enhance community capacity in research for which they would directly benefit by addressing the need for improved transdisciplinary collaborative intervention research, addressing health disparities, and strengthening the science of community engagement. With the implementation of that program, there were several projects funded and that emphasized CBPR methods. An urgent and significant next step in advancing the CBPR program is prioritizing interventions that utilize community-engaged research approaches and that move beyond the individual level of target. Thus, NIMHD has identified an emergent need to shift from prioritizing individual level interventions to more structural level, multi-sectoral, and multi-level interventions. And in this case, specifically with this RFA, community level interventions to improve minority health and eliminate health disparities. Therefore, the primary objective of this RFA is to support research projects to develop and test prospective community-level interventions to improve minority health and decrease health disparities. So talking a little bit more about community-level interventions, since they represent the core of this RFA, as noted previously, a community-level intervention is an intervention that modifies community characteristics, such as the physical or social environment, laws or policies, etc. On this slide, we're highlighting the NIMHD research framework with which you may or may not be familiar. The research framework is a multi-dimensional model that depicts a wide array of health determinants relevant to understanding and addressing minority health and health disparities. These determinants may reflect etiological factors or intervention targets to improve minority health and reduce health disparities. This list of factors is not intended to be exhaustive. Of relevance to this webinar is the community level of influence. Community level interventions might focus on types of determinants such as those listed under the community level of influence. For example, community illness, community functioning, community environment, community resources, again, community norms, local structures or policies, and availability of services or safety net services. So hopefully this gives you kind of some ideas about what we're talking about when we're thinking about and referencing community level determinants. So community level interventions modify community characteristics, but they may also modify individual level characteristics. And again, most importantly, and thus bearing repeating, they target community level determinants of health. Furthermore, a community level intervention employs community engaged research approaches, which I've discussed previously. So what would not constitute a community level intervention from our perspective? An intervention that exclusively helps individuals address, cope with, or manage or navigate community level determinants rather than intervening to change those community level determinants. That would not constitute a community level intervention. And additionally, an intervention that is community based but does not target a community level determinant of health would not be a community level intervention. Also, an intervention that includes maybe community-wide elements, such as maybe factors in the community that are included in the intervention or involve community members, involve community structures, but the intervention effects are only tested at the individual level. That would not constitute a community level intervention. So with that kind of detail about community level interventions, I want to turn briefly to discuss some of the features, expected features of community level intervention projects, specifically related to this RFA. So we're expecting that these projects are to be led by or conducted in collaboration and in full partnership with appropriate community partners, such as community-based organizations, faith-based organizations, local businesses. Again, multi-sectoral collaborations involve partnerships with multiple types of organizations in the public or private sector, and these are strongly encouraged. It's expected that these projects focus on improving health outcomes or reducing health disparities in one or more NIH designated populations that experience health disparities in the US. They're also expected to focus on the entire population in communities. So for example, an intervention to increase the availability of fresh produce or walkable green spaces, or they can focus on a specific population within the community. So for example, an intervention to improve physical activity among high school students or older adults within the community. They're expected to be guided by a clear conceptual model that's identifying hypothesized pathways between the community level intervention, community level determinants, and health outcomes. It's expected to collect data beyond the individual self-reported level to determine how the intervention is impacting community level determinants of health. We're also expecting that these projects prospectively test the impact of interventions on self-reported or measured health outcomes. Retrospective analysis of existing or past community level interventions are not responsive to this initiative. They're expected to include health outcomes at the individual, interpersonal, or community level, or a combination. But again, there must be multiple levels included. It's expected to use appropriate measures and analytic methods appropriate for examining community level mechanisms of action. And finally, it's expected to test interventions that have the potential to be sustainable in the community after the project funding is over. Just very briefly, I should mention that applications that are not responsive to this FOA include projects that do not have a focus on one or more NIH designated populations that experience health disparities, projects that do not prospectively test a community level intervention, projects that only use individual level data, projects that are individual level randomized clinical trials, projects that do not involve one or more community partners as indicated by inclusion of representatives of community organizations as compensated personnel, key personnel, and all of this is in the RFA. So with that, I would just share one more piece, and this is about NIMHD's areas of interest. Overall, we're interested in research that aligns with our mission and the NIH Minority Health and Health Disparity Strategic Plan 2021 to 2025, and that utilizes community engaged research approaches and the NIMHD research framework to assess and intervene on health determinants beyond the individual level at the interpersonal, family, organizational, neighborhood, and community and societal levels. Community level interventions targets of special interest include but are not limited to these listed, and include increasing affordable healthy food options and opportunities for physical activity outside of the home, changing community norms and reducing structural barriers related to health promoting behaviors, for example, breastfeeding, vaccination, physical activity, and preventive health screening. Those are just some examples. Improving community attitudes, for example, reducing prejudice, stigma, or discrimination towards socio-demographic groups, for example, racial and ethnically minoritized groups, sexual and gender minoritized groups, or towards individuals with certain health conditions that might be detrimental to the health and well-being of these populations. We're also interested in promoting screening, detection, help seeking, and self-management related to acute or chronic illnesses. And enhancing the ability of community dwelling older adults to age in place, or individuals with disabilities to live independently and maintain their health and well-being. And promoting community reintegration of the health of individuals who are returning to the community after incarceration or institutionalization, and preventing accidental injury, violence, or suicide, and suicide thoughts and behaviors. So those are just a few examples of some of our specific areas of interest. Listed here are some some research resources that we just wanted to highlight, particularly the Phoenix Toolkit and some research methods resources. Again, these are listed in the RFA, but just wanted to bring your attention to these. That can certainly be used and highlighted in applications. And then application resources. So again, everything from the application guide to information about biosketches. We also want to note that for this RFA, budgets are limited to $1 million in direct costs annually, and this is not including consortium and F&A costs. And so with that, I would like to turn it over to my colleague, Dr. Deborah Ismond, who's going to talk a little bit about peer review.
I want to share my, are you going to do my slides for me? Crystal, otherwise I can't share my screen. Crystal?
Yes, Deborah, I can show your slides.
All right.
But we can, you're very low.
Is this any better?
That's a little bit better.
All right, I'll try and turn my chair so I'm pointing at the microphone. If you'll go to the next slide then. Again, this is, can you hear me now if I speak this loud?
Yes.
All right. I'm an SRO with the Scientific Review Branch at the National Institute of Minority Health and Health Disparities. And so our group is responsible for the review of applications submitted. And because NIH is a research intensive institution, we wanted to make sure that everyone understood the review process because especially for community organizations or individuals who have not necessarily had NIH grants before, it can be very daunting and it is extremely competitive. So we want to make sure that you understand what the process is. Go to the next slide, please, Crystal. Once you submit your application, that's when the sort of process starts where our review branch gets involved. But prior to that, there's some things you can do to help ensure a successful application. One is to make sure that you have all your ducks in a row before you get started and make the intention to submit. It involves having the right expertise, knowing what your concept is, and getting all the materials and registrations that you need to have to submit your review. So I always suggest that people sort of develop their own internal red team to review the application before it's submitted and make sure you submit it before the actual deadline in case there are any errors, pages missing that didn't get through the scanner or whatever. Applications have to be submitted by 5 p.m. local time on the deadline day in order to be accepted for review. So ERA Commons is the way you interface with the NIH system typically. And if you have not do not have that registration access, make sure you get that started, because all the information you're going to need for your application and the submission is involved in that connection. Once your application is received, it's actually being processed by the Division of Receipt and Referral, which is at the Center for Scientific Review, which is the main entity at NIH that reviews most of the grants that we receive. In this case, our IC Institute is doing the review in our internal review branch. Once the application is submitted, you're going to receive an ID number. It's going to receive an ID number, and so you can go into ERA Commons, which will help you be able to find the application and review it to make sure it looks okay. You also need to make sure that everything is complete. Make sure that your bio sketches are up to date, that your information and your own ID within the NIH system is up to date as well, including your addresses, your emails, your phone numbers. Those kinds of little glitches can cause problems. Then once the Scientific Review Center goes through their checks and balances, it gets assigned and referred for review. And in this case, it will come to RIC, and one of the review officers will be assigned to the review. Once assigned, the SRO, Scientific Review Officer, will assemble a panel of external reviewers who do not have any conflicts with anybody or institutions involved in those applications under review. And the purpose of this is to evaluate at the first level of review the technical and scientific merit of the applications received, and to prepare critiques and give scores based on what is presented in each application. After receipt of the application, the program officers will also be looking through the applications to make sure that they are compliant and responsive to the terms of the grant announcement. Non-responsive applications will be withdrawn, and you'll just receive a notice if that occurs. Next slide, please. So I want to briefly go over what the components of peer review are, just so you have an idea of all involved. So I mentioned the recruitment of experts in the field and a chairperson that will make up the review panel. Then I want to also emphasize that in the RFA that you are responding to, you have all the information that we will be using as our review criteria in Section 5 in the request for applications, the RFA. So that's what those are the standards and bullet points that we will be looking at when we review the application. So you may want to focus on those as you're preparing your application, because that's how it will be evaluated. Those same criteria are what make up the structure of the critique template that reviewers then use and fill out once they've been assigned applications. And then at the end, that same critique template and the scores involved will be included in the summary statement that all applicants will receive once the review has been concluded. Once we assign applications, reviewers then read through them, write up their sort of assessments, and then they assign scores. First of all, to the actual criteria. There are 5 NIH criteria for a research grant. These are R01 research grants, which is why we've been emphasizing the research aspects of this. The NIH research framework, it's multidimensional and also multi-level. And also the outcomes, the metrics that you're going to be using to measure community level impact. So make sure that you pay really good attention to that aspect, because reviewers then assign a score. So this is a reductive process. And each criteria, those 5 NIH criteria, will get a score, and then there will be an overall score assigned. In the peer review meeting, we convene all together, and each application is discussed, and then we have a consensus scoring, not consensus scoring, a group scoring based on the information presented, looking at issues like how different scores were weighted, and having discussion about different aspects that might need more clarification, to come up then with a final score. And that final score is how any kind of award would be made, and as well as on the summary statement that's and the comments involved, including our recommendations and strengths and weaknesses. So that's sort of a summary, and we'll go on to the next slide, please, about what to expect. So one of the things I emphasize to review panels is that we are tasked to do a thorough and fair evaluation without bias of the application, and to assess the technical and scientific merits based on these review criteria. So this is the first level of review, and then it goes, it gets summarized in the summary statements, and then the second order of review is at the institute level in the by the advisory committee, and the final decisions are made by program officials and the director in consultation with the program. But in terms of the actual peer review process, I want to point out that everything is considered confidential. We screen for conflicts of interest, and we make sure that all reviewers are aware that the information is considered confidential and privileged. It's a closed meeting when we have it, and no one is supposed to have information about what actually happened during the review meeting, including who was assigned to which application or any of that kind of stuff. So the final summary statement is the report of record for what happened in the review and how the application was assessed. There is supposed to be no disclosure of information about the outcome of review other than that summary statement, and then following that, if there was any interest in award, you would be getting direct communication from program. All right, next slide. Now, peer reviewers tend to be very experienced with NIH grants and as researchers. We also try to make sure that we include persons with the appropriate experience. So in this case, working with different methods for community engaged review, as well as in the methods used for evaluating community level impact. So when you are preparing your application, make sure you're looking at those review criteria in section 5 to see what they're going to be tasked to look at for evaluating your application. Those are going to have the specific NIH review criteria, the 5 specific criteria, and looking for score driving issues in terms of strengths and weaknesses. So all of that then gets reduced to a final overall impact score. And there are also things like completeness, whether all the bio sketches are up to date, those kinds of things that sometimes impact scores, but we try to make sure that the same criteria are used for all applications. So it's a very competitive kind of thing, so know that in advance. Make sure you have the appropriate expertise advising you in terms of your metrics and your research designs. Make sure you take advantage of the tools mentioned in terms of the Phoenix toolkit for outcome measures that can be good metrics of community level outcomes. And also the research methods resources that might be available to help you make sure that you're on the right page in terms of your research methodology. Next page. These are the 5 research criteria I kept referring to. Number 1 being significance, 2 investigator, 3 innovation, 4 approach, 5 environment. Where most applications get fouled up or run into trouble is in the approach section. It's very important that you have that conceptual model so that you have testable study questions or hypotheses that you are sort of setting out, or if it's a mixed method approach, how the first stages that you're conducting are informing how you will go forward, toward the conduct of a clinical trial or whatever it is that you're proposing. But just make sure that you have really well organized the application, that you are responsive to the review criteria for these specific aspects, because those are the ones that get the individual scores. And then the overall impact score is what is the final reduction of the assessment. There are some additional aspects, including scoreable criteria, and then additional review considerations that are non-scoreable that may have an impact on the assessment. So make sure you pay attention to all those things in the section 5 as you're preparing your application. If you are doing a clinical trial, that is something where you have to take additional steps to make sure that you're following the review criteria, anything specified in the review criteria. If it's involving a clinical trial, especially with human subjects, make sure that you have included your specific methodologies for sample selection and for describing the inclusion of those subjects that you are going to include in the trial. Next slide, please. Next slide, please. This is just another slide with the actual questions that might be in there. These are the standard ones for NIH. So look at the ones that are in your RFA on section 5, just to make sure that there are no other specific aspects that are being emphasized because of the community level aspect of this research. Next slide. I've sort of described this process already, but again, this is here for reference once you download this. But we use a 9-point Likert scale at the NIH for coming up with our assessment scores. It ranges from 1 being the best to 9 being the lowest. Exceptional or poor is how we, the adjectives we use. And that is applied both to the individual research criteria and then also when making the overall impact score. Impact is typically grouped into 3 categories, the overall impact. So if the scores are 1 to 3, that's usually meaning the panel has assessed it to be a potential high impact. A score in the 4 to 6 range is more medium impact as it was presented. That's how the panel is assessing it, and then below that would be low impact. So the final composite scores that are a result of the review meeting are released almost immediately following the meeting. These are the mean overall impact scores of the assessed applications, and this score is a composite score, but it will also be the score that's listed on your summary statement when you receive that. All submitted applications that are under review for the panel, by the panel, will receive a summary statement. Those that are discussed, because some may not be discussed if they are not high enough scoring. So the applications that are discussed will have a summary statement as well as the individual reviewer critiques And if it's not discussed, it'll just have the reviewer critiques, which provides feedback to the applicant and to program in case there are questions. All right, next slide, please. This is the summary statement, a little bit more information about it, but that's the official documentation of the review process. It usually comes out about 30 days after the review, and the front page will indicate who the assigned project officer is on the upper left side. So that will be your contact if you have any questions going forward, or for whatever reason. And discussed applications, again, recommend the application based on the score, where the overall composite score falls, and can be considered for funding. The SRO write-up provides a summary of the discussion and major strengths and weaknesses. And then you also have the additional critiques written by the assigned reviewers. There are also maybe additional comments or sections with these additional scoreable or non-scoreable aspects that might involve human subjects and issues or administrative notes. If there is something that was noted by the panel, and it just gives a heads up to program or to the applicant if they are being under consideration for funding. Applications that are not discussed have an MD designation on the summary statement instead of a composite score, which may also be a plus assigned on the face page. But if they do include the written comments from assigned reviewers and scoring for the 5 criteria. Next page, please. So what happens following the peer review meeting? A lot of times people aren't quite sure. It's sort of like there's that time lapse between when the summary statement comes out. But basically, that process is followed, and then the NIH program officers will consider the impact score and summary statements that result from the review process and see which applications are best aligned with Institute priorities. Then there is a second level of review that occurs at the next advisory council, which for this particular RFA will be the January 2024 council. And that council members are scientific and public representatives chosen for their expertise, interest, or activity in matters related to health and disease. And they will also consider the recommendations from program and make further recommendations that will be taken under advisement by program, and the director will make final funding decisions. If you are considered for funding, you will probably receive a just-in-time request, but oftentimes there's confusion about that. So again, that's where if you get any kind of notification or something, you can always reach out to the program official listed in that summary statement. Next, please. These are just resources. Again, I want to remind you of those resources that were listed for the methodology and research aspects, as well as the application process itself. And that resources for applications using ERA Commons is a good link to get started if you're not familiar with ERA Commons. If there's any problems with the with submitting your application, you probably want to get in touch with the help desk because there's some kind of technical issue going on. And there are some videos that the center has for scientific review has put together if you are interested in getting more information about the actual process or preparing your application. And then there is a policy about just-in-time procedures if you do get one of those notices, which may indicate that you are under review for funding. I think that's it. Go on to the next slide. Yeah. Okay, thank you.
Yep. Okay. Great. Thank you so much, Deborah. So we're going to now wrap up. Just very briefly, I'm going to talk about the timeline. So the letter of intent, which is not required, but that was due 30 days prior to the due date. So that would be today. The application due date is July 7th, 2023. So again, in about a month, or a month exactly, I should say. The peer review meeting, which Deborah described in detail, excuse me, Dr. Isman described in detail, that is scheduled for sometime in November. The exact date is not yet scheduled. And then the council meeting, as Dr. Isman mentioned, will take place in January of 2024. So that will mean that the earliest start date for funded grants, awarded grants, will be in April, approximately, I should say, approximately April 2024. Okay, so that that gives you a general sense of the timeline for this RFA. Again, letters of intent would be due today, but they are not. They are recommended but not required. Okay. Here are just a few NIMHD contacts listed. Again, I am the scientific contact for this RFA. The peer review contact is Dr. Isman, and the fiscal and grants management contact is Priscilla Grant. And again, this information is provided in the RFA, where the NIMHD contacts for other offices are listed in the RFA as well. And so with that, I think we do have some time left for questions. And I think there are some, I've seen some questions come in the chat. So I'm going to stop sharing my screen so I can open up the chat. And Jennifer, thank you. Dr. Alvidrez is now on screen and can help us navigate the chat.
All right, ready for the first question?
Yes.
Okay. Do military veterans fall within the category of, I'm assuming, of health populations that experience health disparity?
Okay. So not in terms of an NIH designated category. I think if you're talking about a population that experiences health disparities, that would not, military veterans are certainly, I'm sure, experience health disparities, but not in terms of an NIH designated population.
Okay. And we could add veterans who do fit those other populations.
Right.
Would be appropriate.
Right. Yes. Yeah. So if there's certainly there's some intersection, I'm sure if there's intersection with the populations, with the intersection of NIH designated populations, then that would certainly apply.
Okay. Next question. Would older adults living in various nursing home settings fall within the parameters of the RFA? I'm not sure in terms of the parameters, kind of, if you mean in terms of the community or the populations of interest, maybe some additional clarification. Right. And just
would be
helpful.
helpful.
If I could add, if you have a super specific question about your own project and whether it fits, then you should contact Crystal.
Yes.
For those details. So I think because some of the answers is it really depends on what you're talking about and what your study is to
Yes.
know whether it fits. So
yes.
I think that one falls within that category.
Yes. Yeah. So so we're certainly happy to meet with you and talk with you about specific questions and provide technical assistance on AIMS. And I see a hand, but if you could please enter your question into the chat, that would be helpful. Okay.
Okay.
Next question.
The next question is about the expectations for outcomes beyond self-report, if not partnering with the health system.
what is enough to meet the community-based social determinants of health outcome? And I'll, if I may, I'd like to add on to your response, Crystal.
Sure. So in terms of enough, I don't necessarily think there's a benchmark or a kind of benchmark in terms of enough. The expectation is that, again, the expectation is that there's an impact on community level determinants, and so obviously that you're measuring community level excuse me, outcomes. And obviously that you are partnering. I think the question mentioned partnering with
Outside of a health system. So not partnering with, having other partners besides health systems.
So regardless of partnering with a health system or not, again, the expectation is that the intervention would impact a community level determinant and community level health outcomes. And so I think, so now there can certainly be impact on individual level outcomes, or any kind of multi-level outcomes, but obviously the expectation too is that there's a community level impact. Jennifer, did you want to add something to that?
Yeah, just to make a distinction between responsiveness and a good application. Mm-hmm. So there is a minimum, a responsiveness criteria is that you have to have some sort of data beyond the individual level for your application to be reviewed.
Right.
And then the reviewers will decide whether your outcomes or your determinants or what you're measuring, they'll assess the quality of that, whether it's meaningful and appropriate. So it's sort of a two-part answer to that question, I think.
Right. Right. And that, I think that will obviously depend on your questions, your design, the intervention, that will, I think, depend on a host of other factors. So there, I mean, obviously with regard to responsiveness, and the expectation is that it's beyond the individual level. So there is the enough, in that there needs to be a demonstration of something beyond the individual level. But in terms of how much, yeah, I think it depends on what you're proposing.
Okay. Next one. Can you confirm the page limit for the research strategy and whether references are included in the page limit?
I'm going to throw that one to Deborah. I think I can remember, but Deborah.
I'm sorry, what was the question again?
The page limit for the research strategy and whether references are included in the page limit. And I can answer that as well.
I think it's 12.
I really haven't looked at it to know.
Yeah.
Generally, we encourage a very strong, significance with lots of literature citations to justify, the rationale as well as the methodologies, etc.
And yeah, and to just to confirm, the research strategy is 12 pages.
It's 12.
And there's a separate attachment for the bibliography and references cited. So those aren't included in that 12-page limit. They're a separate document.
Thank you. Yeah.
Okay. There's a question which may be a contact Crystal question for a study with outcomes. For a study on individual reintegration following incarceration, what are organizational and community outcomes?
Yeah, I saw that one. Let's contact me offline.
Yep.
We can discuss that one.
What is the bio sketch?
So it's a brief summary of your work, your academic history and your career history, but it's a specific format. I was trying to find I couldn't open the link for that respondent, but we can post the link. But there's a resource about bio sketches, I think actually posted in the slides.
And in the SF424 application guide, certainly there's guidance on the bio sketch.
And how to construct a bio sketch.
Yeah.
But it's not it's similar to a resume, but it's really a summary of your educational history, but also your career history.
This is Deborah. Yeah, it's a standardized format, and it should be up to date and current for all the key personnel.
I don't know if everyone heard, it's she mentioned it's a standardized format that should be up to date, and it's for everybody, including key personnel. I saw some people.
Let's see, next question. So there are a couple of questions I'll combine. Are there additional receipt dates and/or are there plans to reissue this RFA?
At this point, we don't have any indication that there's an intent to reissue. So suggestions would be, there's always the parent. You can always consider submitting to the parent award, a parent mechanism.
This is Deborah. There is an option enlisted in the RFA if it's an AIDS-related application for a late submission. Are you? It's listed in the RFA. Just mentioning that.
I'm sorry, Deb. I'm sorry, Deb. Can you repeat that?
There is in the RFA. It mentions that a later AIDS-related submission applications that are AIDS-related can be submitted at the later date.
So sorry. Yeah. Okay. Thank you, Deborah. So there is the date for AIDS-related applications is August 9th. But that's just for AIDS-related applications. And then the RFA does expire. And I saw, sorry, Jennifer, I see there's a note about clarification, the parent mechanism. So that's an investigator initiated award. It's an R01, kind of a blanket R01 award, a grant. And you could find this, let's see, we could provide that link.
Ready for the?
Yep.
Okay, so I'm skipping over some that are contact Crystal questions.
Yes.
For very specific. Does this grant allow for creating fixed or permanent community assets, for example, smoking areas?
I'm sorry, could you repeat that?
Can you use this grant to create fixed or permanent community assets, such as smoking areas?
In terms of the intervention?
I think in terms of an allowable cost.
Oh.
And I can jump in and say there's
Yeah.
nothing that says the resources need to be only last as long as the project,
Right.
but they do need to be allowable costs. So work with your contracts and grants people regarding what allowable costs are. Certainly NIH does fund things in the area of like building green spaces and things like that,
Right.
but it has to be allowable. So just work with your budget and reach out to Priscilla Grant,
Yes.
Which was on the slides if you have questions about
Allowable costs. Yes.
This is Deborah. Also, the sustainability aspect is something that was a positive, in my opinion, if you are using funds to address sustainability after the grant ends. That might be a way to do things. I'm not sure about everything, but it's certainly a way you could consider extending the impact of the project in the future.
Okay, next question. Is it okay to submit the letter of intent by COB today?
Yes.
Yes.
Should partners be listed as key personnel, or is a letter of support sufficient?
So partners should be listed as key personnel.
Right, and it's actually a responsiveness criteria, which you were going to say that, Crystal.
Yes, that's a key component of responsiveness.
And letters of support are always important.
Is there a preference for a community-based institution or principal investigator or multiple principal investigator?
You mean an MP?
I'm
sorry.
I'm gonna.
Yeah,
Is there a preference for an academic or a community?
is that the
Yeah,
question?
I assume that's what the question is about.
Okay. Sorry, I was trying to find it. I don't know if I want to answer that. So I think it's about demonstrating the partnership, and so oh, I'm sorry. So the question is academic versus community. So again, in the nature of it being community based, and emphasizing community engaged research. I think certainly academic partnerships and partners are I think acceptable. But again, I think we really do want to ensure a community-based presence and a community partner and community-based presence.
This is Deborah. Just to add on to that, Crystal, they might want to, if they're a community-based partnership, but they're concerned about the academic aspect and the research aspect, they may want to consider like an evaluator as a partner.
Sure.
Next question, if a letter of intent is optional, it's not evaluated, correct?
Correct.
That's correct. It's more for preparation of the review, so if anyone is really intending, you just let us know, but it's not required. It's just more informational and a courtesy.
Next question, can you have community level outcomes that are not health outcomes? For example, organizational networks.
As an organizational network, as an outcome. Yeah, but I think we should also talk. I'd like to follow up, just understand a little bit more. And again, this is a health, the obvious, the focus is on health. So, I think there's also some other factors that would need to be considered.
All projects need to have some sort of health
There
outcome.
needs to be some health outcomes.
Yeah.
Again, this is Deborah, it may be something that's in your conceptual model. Like, so if you're hypothesizing that increasing the amount of networks within the community may improve XYZ outcomes in terms of, physical activity groups or something like that, you just have to make sure it's clear. So check with Crystal.
There are a couple of questions about the letter of intent. Where should it go? That information is, I'm just speeding up, Crystal, to answer quickly.
Yeah.
That information is in the RFA.
Correct.
And someone is asking for a sample. Just provide the information that's requested. As was stated, it's not evaluated. It doesn't affect the evaluation of your application. So it's pretty simple to help review, find appropriate reviewers. So don't stress too much.
No.
About the letter of intent. Is just to help with review.
And it's not required. It's not. Yeah. It's not required. I see this last question. It is not required. So yeah, it's helpful, but for us, but it's not required.
Right. So we have 1 minute left. Do you want to close?
Yes. So again, we thank you for your participation. Thank you for attending. Again, if you have any other questions, please feel free to contact us. We are very excited again about this program and this initiative. So we look forward to hearing from you and working with you. And again, feel free to reach out. Looking forward to a successful program. Thank you.
Thank you.